Imagine a fire alarm, right? But it just keeps ringing for months, maybe even years after the actual fire has been, completely put out.
Oh, that sounds awful. But it's an incredibly accurate comparison.
Yeah, and for millions of women, this is reality. Like a completely cured, practically invisible yeast infection can permanently rewire the nerve endings at the entrance of the vagina.
Right, turning just the gentle friction of intimacy into the sensation of severe burns.
Exactly. So, welcome to the deep dive. Today, we're unpacking a condition that forces just an enormous number of women into silent suffering.
We're talking about entry pain dyspareunia,
Yeah,
or as the medical literature calls it, superficial dyspareunia.
right. And our mission today is laser focused on answering one critical question based on a massive stack of medical sources. Basically, what actually causes this?
And we're pulling from some really robust sources here. The
Mhm.
BSHH guidelines, that's the British Association for Sexual Health and HIV plus NHS patient pathways, and a variety of specialized clinical reviews.
Yeah, and whether you are experiencing this yourself, or maybe you have a partner who is, or you're just curious about human biology, this is crucial to understand because so many women just suffer in total silence out of embarrassment.
They do. And since we already know the basic mechanics of dyspareunia, which is just pain during intercourse, we really need to strictly isolate this superficial entry-level pain.
From the deep stuff, right?
Right, exactly. We're separating this from deep pelvic issues like endometriosis or ovarian cysts. The biological triggers at the introitus, which is just the anatomical entrance to the vagina, are vastly different.
So we're really looking at this highly localized intersection of, well, dermatology, neurology, muscular reflexes, and psychology.
It's a very busy intersection.
It really is. And we need to start with the immediate, everyday environment of that tissue. Because before we even look at chronic diseases, the sources highlight that the initial trigger is often just sitting right on your bathroom shelf.
Yes, the everyday culprits. We're talking about contact dermatitis,
Yeah.
from scented soaks, shampoos, bubble baths.
Or even allergic reactions to latex condoms and
Um,
the spermicides coating them, right?
Exactly, because the vulval tissue is incredibly permeable. It's so sensitive. So an immune response to a seemingly harmless shower gel can cause just profound swelling and burning.
Wow. Okay, let's unpack this. Because the problem is what happens next. The NHS pathways outline this physiological trap called the negative cycle.
Right, the negative cycle is so critical to understand here.
Yeah, so say you have that allergic reaction or maybe a simple temporary infection like thrush or, a genital herpes outbreak. You experience severe pain during penetration.
And if that happens a few times, your brain naturally develops a fear of that pain.
Which makes sense. But fear is the ultimate killer of sexual arousal. I was reading about the physiology of this, and it's fascinating. It's like flinching right before you get a vaccine shot at the doctor's office.
Oh, that's a great way to put it.
Right, because you anticipate the needle, you tense up your arm muscle, which actually makes the injection hurt far more than if you had just, stayed relaxed. Is that kind of what's happening here?
That is exactly what's happening. The lack of arousal fundamentally changes the physical environment of the vagina. It shuts down the entire preparatory sequence.
So the body just halts everything.
Yeah. When the brain senses fear, the sympathetic nervous system, the fight or flight response, completely overrides the parasympathetic nervous system, which is what governs arousal.
Wow. And without arousal, what happens physically?
Well, there is no vasocongestion. Blood doesn't rush to the pelvic area, which means there's no transudation.
Transudation, that's the moisture being pushed through the vaginal walls, right?
Exactly, to create natural lubrication. So attempting penetration in that dry, unyielding state drastically increases friction.
Which creates micro tears in the tissue.
Right, guaranteeing that the pain is significantly worse.
So the anticipation of pain literally engineers the biological conditions for more pain. That is wild. And that cycle destroys libido, makes orgasm impossible, and it really fractures relationships.
It really does. It leads to profound relationship difficulties.
So step one is recognizing and removing the everyday irritants, or treating the immediate infection to stop that cycle before it solidifies.
Right, get rid of the scented soaps, treat the thrush.
But what happens when you do that? Like you swap out your soap, you clear up the initial infection, and the pain at the entrance is still just agonizing. The BSAH guidelines shift the focus entirely to chronic skin conditions.
Yes, the dermatosis. This is where the body essentially turns on itself and the tissue itself begins to break down.
And the main one they talk about is lichen sclerosis, right? LS.
Yeah, lichen sclerosis is the most prominent condition the guidelines flag. The evidence strongly points to it being an autoimmune disorder.
Meaning the immune system mistakenly attacks the healthy mucosal tissue of the vulva.
Exactly. It presents as these pale, thinned, atrophic areas of skin that are prone to severe itching and fissuring.
And fissuring, I mean, those are essentially tiny, agonizing paper cuts all around the vaginal entrance, right?
That's exactly what they feel like.
The phrase that really stood out to me in the clinical reviews was loss of architecture.
Yes, it's a very clinical term, but a very descriptive one.
It sounds almost architectural, like a building collapsing.
Yeah.
But applied to human anatomy, it means the disease can literally fuse the labia minora together.
Yes, it completely narrows the vaginal entrance. They call it introital stenosis.
Wow. So if the physical entryway is narrowed and the surrounding skin is as fragile as like wet tissue paper, any attempt at intimacy is going to cause structural tearing.
It is a devastating progression if it's left untreated. And the guidelines also bring up lichen planus.
That's the one that causes the typical papules, right?
Right, painful raised papules and internal mucosal sloughing. And interestingly, they also highlight genital psoriasis.
Okay, the psoriasis mentioned threw me because the sources link it to something called the Koebner effect, which is incredibly counterintuitive.
The Koebner effect is fascinating, yeah.
It essentially means the body's healing response gets hijacked. Like, if you have psoriasis, any physical trauma or friction to the skin prompts the immune system to overreact.
Right, and it forms a brand new psoriasis plaque exactly on that line of friction.
So the very physical act of sexual intercourse actively triggers a skin disease flare-up at the entrance. That is, I mean, that's wild.
The friction itself becomes the pathogen. It is a brutal biological irony.
Seriously. And speaking of tissue integrity, we cannot ignore the hormonal foundation of all this. The sources dedicate a massive section to genitourinary syndrome of menopause, or GSM.
Yes, GSM.
Which, by the way, is the updated, much better term for what used to be called vulvovaginal atrophy. It covers the profound changes that happen when estrogen levels plummet.
Whether that's from natural menopause, breastfeeding, or even certain low-dose birth control pills.
Right, but I want to understand the actual mechanism here. Like, how does estrogen physically prevent this entry pain? What's it doing?
Well, think of estrogen as the master architect of the pelvic floor. It actively maintains the thickness of the epithelial layer.
That's the skin lining the vagina and vulva.
Exactly. It promotes blood flow, ensuring elasticity, and it dictates the production of glycogen.
And glycogen is important because
that glycogen feeds the healthy lactobacilli bacteria. That keeps the environment beautifully acidic and resistant to infection.
Oh, wow. So when estrogen disappears, that entire ecosystem just collapses.
It does. The tissue becomes incredibly pale, thin, and friable.
Friable meaning it bleeds easily upon contact, right?
Right. Without estrogen structural support, normal friction translates immediately to deep tissue pain.
Okay, so we've mapped out external irritants, we've got autoimmune skin conditions melting the architecture, and hormonal droughts starving the tissue.
Right, that covers the surface level issues.
But let's follow the causality here. Say a patient goes to the doctor, they get their estrogen levels balanced, their skin is perfectly clear, no lichen sclerosis, no psoriasis,
right?
Yet the entry pain remains impossible to push through. If the surface is fine, the problem has to be what's lying just beneath the surface, right? The muscles.
Exactly. The brain remembers the past pain and triggers a muscular barricade. The pelvic floor muscles just take over.
And the specific condition here is vaginismus.
Yes, vaginismus. The pubocaceus and rectococcygeus muscles essentially go rogue. They slam shut in a severe, completely involuntary spasm.
So the patient is not choosing to tense up.
Not at all. Their nervous system perceives the approach of penetration as a threat and reflexively locks the entrance. It makes sex either exquisitely painful or literally like hitting a brick wall.
So if a listener has this, is it just a physical reflex or is the mind playing a role here?
What's fascinating here is that the DSM-5, which is the Diagnostic Manual for Mental Disorders, actually combined vaginismus and dyspareunia into a single category.
Oh, really? They group them together?
Yes. They call it genitopelvic pain penetration disorder because they essentially argue that you cannot separate the physical muscle spasm from the psychological anticipation of pain.
Because they fuel each other continuously.
Right. The physical reflex is driven by a psychological state, which is then validated and reinforced by the physical pain that results.
That makes so much sense. But it is important to note that muscular blockades aren't the only structural issues, right? Physical trauma leaves lasting changes.
Definitely. Postpartum scar tissue is a major factor here.
Like if a woman experienced an episiotomy or a severe tear during childbirth.
Exactly. The resulting scar tissue does not contain elastin. It cannot stretch like healthy mucosal tissue.
And the review on aesthetic genital surgery also points out a growing, entirely avoidable cause, iatrogenic or doctor-caused scarring.
Yes, from procedures marketed as cosmetic enhancements.
Right, like labial reductions or vaginal tightening, they can inadvertently result in excessive scar tissue or an over-tightened introitus.
The patient goes in for an aesthetic change and comes out with a permanent structural narrowing that directly causes superficial dyspareunia.
Because anytime you cut into that highly innervated, delicate tissue, you risk altering its mechanical function.
Absolutely. Which brings us to the most complex, arguably most frustrating category in all the sources.
Yes, what happens when you rule out everything? The skin is healthy, hormones are optimal, muscles are relaxed, and there is no scar tissue.
Yet the pain is unbearable.
Here's where it gets really interesting. This is where we get to the fire alarm analogy from the very beginning. The condition is called vulvodynia.
Yes, vulvodynia.
The ISSVD, the International Society for the Study of Vulvovaginal Disease, defines it as burning pain occurring without relevant visible findings.
Or any clinically identifiable neurological disorder.
Right. Specifically for entry pain, it's localized provoked vulvodynia or vestibulodynia. Localized to the entrance, provoked by touch.
And doctors test for this with a very simple Q-tip test.
Oh, right, where they gently touch the vestibular tissue with a cotton swab.
Exactly. And if the patient experiences severe burning, stabbing pain, but everything looks perfect visually, that's the diagnosis.
The hardware looks fine, but the software running the nervous system has been corrupted.
That's a perfect way to phrase it. And as you mentioned earlier, the BHH guidelines note a striking pattern.
Yes. The most commonly reported history in these patients is recurrent thrush, recurrent vulvovaginal candidiasis, repeated yeast infections.
Yes.
This is the part that blew my mind. How does a yeast infection you cured 5 years ago cause burning pain today?
That's a great question.
It's like your computer getting a virus. You run the antivirus software, the bug is deleted, but it permanently corrupted the code for your keyboard.
Right.
Now, every time you press the space bar, the system just crashes.
That is a brilliant analogy. Experimental animal studies show that repeated fungal infections cause neuroproliferation.
Neuroproliferation, so an actual increase in the density of nerve fibers in the tissue.
Exactly. And those nerves become locked in a state of hyperexcitability. The medical term for this is central sensitization.
So the nerves start interpreting a normal, gentle touch, like a cotton swab or sexual penetration, as massive tissue damage.
Right, they fire off maximum pain signals to the brain. The infection is long gone, but the alarm system is broken and stuck in the on position.
Wow. And the mind-body link here is profound, too. The clinical reviews highlight that the nervous system doesn't just hold on to physical trauma like a yeast infection, it holds on to psychological trauma, too.
Yes, a significant number of women dealing with this have a history of anxiety, depression, or sexual abuse.
The body literally keeps the score, manifesting unresolved emotional trauma or deep chronic stress as localized, hypersensitive physical pain right at the vaginal entrance.
Because the nervous system is a unified network. You really cannot isolate pelvic nerve pain from the brain's emotional processing centers.
Right. And because the causes of entry pain dyspareunia are so wildly diverse, from autoimmune skin diseases to corrupted nerve software to muscular reflexes, the treatment has to reflect that.
Exactly. The British Society for the Study of Vulval Disease insists on a multidisciplinary treatment approach. There is no single magic pill here.
You often need a gynecologist, a pelvic floor physiotherapist, a psychologist, and a pain specialist all talking to each other.
The whole team.
Yeah. Now, the baseline behavioral and lifestyle fixes are straightforward. The easy wins: ditch the harsh soaps, use water-based lubricants like SYLK, as mentioned a lot, and wear 100% breathable cotton underwear.
Avoiding douching and hot baths, too. But the medical interventions are where the science gets really targeted.
Right. Let's get into those.
If someone has those hyperactive misfiring nerves from vulvodynia, the BHH guidelines recommend an immediate localized override. 5% lidocaine ointment applied to the entrance 15 to 20 minutes before intimacy.
Which temporarily numbs the overactive nerves, breaking the expectation of pain, though the guidelines include a very practical warning.
Oh yes, a very important warning.
You absolutely must wash off the lidocaine just before penetration or ensure a condom is used. Otherwise, that numbing cream transfers, and suddenly the partner is experiencing profound penile numbness.
which introduces an entirely new set of problems into the bedroom.
A crucial logistical detail for sure. But if a topical cream isn't enough to quiet the nervous system, they move to pain modifiers.
Right. The guidelines suggest tricyclic antidepressants, like amitriptyline.
And it's important to clarify for the listener, they're not prescribing this because they think the pain is just depression.
Far from it. In very low doses, starting around 10 milligram and titrating up to maybe 75 or 100 milligram tricyclics, alter how the nerve synapses transmit pain signals to the brain.
Oh, so they act like a volume dial, turning down the hypersensitivity of those corrupted nerve pathways?
Exactly. And medications like gabapentin serve a similar function for chronic nerve pain.
Okay, so that targets the nerves. Let's pivot back to the tissue architecture, the hormonal side of genitourinary syndrome of menopause.
Right, the GSM.
The obvious solution to an estrogen drop is vaginal estrogen, applied locally to rebuild the tissue. But the NICE guidelines tackle a really tricky nuance here.
Yes, the breast cancer survivor guidelines.
Yeah, what about women who have survived breast cancer and are explicitly told that estrogen could trigger a recurrence?
The NICE guidelines emphasize that even for many breast cancer survivors, localized vaginal estrogen can sometimes still be remarkably safe.
Because it is applied directly to the vaginal mucosal tissue in microscopic doses, so systemic absorption into the broader bloodstream is almost negligible.
Exactly. It doesn't circulate the way an oral hormone pill would. It requires careful specialist input, of course, depending on the estrogen receptor status of the previous cancer, but it shouldn't be automatically ruled out.
And for those who cannot or will not use hormones, the sources highlight a newer oral medication called ospemifene, or non-hormonal moisturizers.
Right, prastrone's another alternative.
But ospemifene is brilliant. It acts like a biological skeleton key. It fits perfectly into the estrogen receptors in the vaginal tissue, unlocking all the plumping and lubricating benefits, but it purposefully does not activate the estrogen receptors in the breast tissue.
It's a marvel of selective receptor modulation, really.
It really is, but remember, fixing the tissue or numbing the nerves doesn't automatically stop a muscle spasm.
No, it doesn't. For vaginismus, physical therapy is the gold standard, specifically the use of vaginal trainers or dilators.
I looked at the clinical reasoning behind the dilators, and it is entirely about neuroplasticity retraining the brain.
Right, slowly rebuilding confidence.
Yeah, they come in a set of gradually increasing sizes, and the genius of the therapy is that the patient is in total uninterrupted control.
They use the smallest dilator while practicing pelvic floor relaxation techniques.
And as the brain realizes, wait, something is entering and I'm not in pain, the negative cycle shatters.
They are decoupling the act of penetration from the anticipation of pain. As confidence grows, they slowly move up in size.
It's incredible. And it's paired with pelvic floor biofeedback therapy, where patients use sensors to visually see on a screen when their pelvic floor is tensing.
Teaching them conscious control over an involuntary reflex.
And because that physical reflex is so deeply tied to fear and anxiety, cognitive behavioral therapy, or CBT, is huge here.
To break those negative thought patterns, yes.
Yeah.
Mindfulness helps them stay in the moment rather than anticipating pain.
Plus, psychosexual counseling, all woven into the treatment to rebuild both the patient's relationship with their own body and their relationship with their partner.
It really takes a village to treat this comprehensive.
It really does.
Exactly.
So what does this all mean? If you take one thing away from this deep dive, let it be that entry pain dyspareunia is an intricate, highly treatable biomechanical and neurological puzzle.
It is absolutely not just being tense.
No, it is corrupted nerve software, it's autoimmune architecture collapse, hormonal starvation, and protective muscular barricades.
But the most tragic aspect of this condition is the silence surrounding it. Consider this. If someone tore a muscle in their knee, or if they had a chronic bleeding skin condition on their arm, they wouldn't hesitate for a second to seek out a physical therapist or a doctor.
Right, they would demand a treatment plan.
Exactly. So why do we allow the mere geography of this pain, simply because it occurs in a sexual context, to dictate whether or not it deserves medical attention?
It's so true.
Imagine how much silent suffering and how many fractured relationships could be completely prevented if we destigmatize sexual pain and treated it with the exact same routine urgency as a sprained ankle.